Good evening, everyone. My name is Carolyn Brown, and I'm the Senior Associate Director of Development and Community Engagement at the Vassar Center. On behalf of Vassar's Parents Leadership community, I would like to welcome you to tonight's Pearls of Wisdom discussion. Tonight's discussion will focus on fertility preservation, egg freezing, pre-implantation genetic testing, and more. Please consult with your healthcare team should you have any questions about the specifics of your personal health and medical plan. The PLC is a supportive forum for parents of children who have or may be faced with a BRCA genetic mutation, in addition to serving as a resource to stay informed about the latest advances in BRCA research and care. For the young adults joining us tonight, you should know that the Vassar Center also has the Young Leadership Council, a group of 194 BRCA-affected men and women across the country who come together to stay informed about the latest advances in BRCA-related cancer research and provide a community of support. There will be time for Q&A at the end of our discussion. Questions can be sent to my attention in the chat. We will also be addressing as many of the pre-submitted questions as we can. Now, I would like to introduce tonight's esteemed speakers. Dr. Susan Domchek is the Vassar Professor in Oncology at the Perelman School of Medicine at the University of Pennsylvania. She serves as Executive Director of the Vassar Center for BRCA and Director of the Mary Ann and Robert McDonald Cancer Risk Evaluation Center. Her work focuses on the genetic evolution and medical management of individuals with inherited risk factors for cancer. Dr. Clarisa Gracia is the Nancy and Richard Wolfson Professor of Obstetrics and Gynecology and Chief of the Division of Reproductive Endocrinology and Infertility at the University of Pennsylvania. Dr. Gracia established the Fertility Preservation Program at Penn Medicine in 2007, and since then, she has been actively involved in caring for patients seeking fertility preservation for a variety of conditions in collaboration with Penn's Abramson Cancer Center and the Children's Hospital of Philadelphia. And with that, I'd like to turn it over to Dr. Domchek.
Great, thank you so much. And thanks to all of you for being here. Clarissa and I are going to have a conversation today, so this is going to be a little bit of just of a back and forth, addressing the questions that we commonly have put to us by our patients, and also addressing some of the questions that you've given in advance. We recognize that these issues are actually quite complicated, and everyone's going to have a little bit of a different perspective and an opinion on where they go from here. So just to sort of level set, and I know a lot of you in the room know a lot about this already, but just to sort of start with some basics. Dr. Gracia, why don't you tell us a little bit about, egg freezing, embryo freezing, pre-implantation genetic testing? Can you define some of these terms for us?
Okay, so egg freezing basically involves the stimulation of the ovaries. And I don't know how much in detail you want me to get, Susan. I can go from beginning to end, or we can, be more general. But basically, when somebody comes to see me, we first start an evaluation to kind of figure out if somebody's a good candidate for freezing their eggs or embryos. And so we do things like get a pelvic ultrasound, see if the ovaries are accessible, is the uterus normal, and do some tests to determine the ovarian reserve, which means kind of how many eggs a woman has in her ovaries. So we can do some hormone tests to measure something called the anti-Müllerian hormone. That helps us understand how many eggs a woman has. And then the process itself, if we have a good number of eggs and she's a good candidate, essentially involves her giving herself injections of follicle stimulating hormone under the skin for about 2 weeks. Typically a cocktail of about 2 to 3 injections per day. Some stimulate the growth of the eggs, some prevent the release of the eggs. And then basically, when ready, the woman goes through a minor surgical procedure, typically under sedation, where we put an ultrasound in the vagina with a needle attached, go in and aspirate the fluid from the ovaries, from the follicles, and gather eggs. Egg freezing means that we take the eggs that have matured, we take off the outer layer of cells to determine the maturity, and we essentially freeze those eggs that have reached maturity. That's what we do for egg freezing.
And can I just ask you, even with that, I think, it's really helpful to know that it takes about 2 weeks, kind of once you get the go signal. But from the time that someone starts the process, say someone's like, okay, I'm interested in freezing my eggs, like how long does that whole workup, et cetera, take?
Yeah, that's a great question. I think some first of all is getting an appointment with the doctor. Sometimes that takes a little while, and depending on where you live, it may be easier or harder to get an appointment. Let's say it takes, I don't know, 3 to 4 weeks to get an appointment. Then you have a consultation, talk about the process, get the blood work done. A lot of people request that the blood work be done like between day 2 and 4 of the menstrual cycle to get an assessment of not only AMH, but also hormones like follicle stimulating hormone, get an idea, how many eggs the woman has. And so you have to wait for your period, get the labs. Often we use the birth control pill for a couple of weeks, not only to coordinate the cycle start, but it also helps to quiet the ovaries down so that when we do start stimulation, the eggs grow in a more synchronous fashion. So probably that could be, 2 to 3 months to kind of get that orchestrated. There's also sometimes a wait in terms of how quickly you can start. Every program is different in terms of how many people they start every week. And you can imagine you can't have a program that just starts a huge number 1 week and few the next. So we try to even it out. And so there could be a little bit of a delay in that.
And when you say, the eggs maturity, do you have a sense of if you're, again, you try to start at the same time, so all the eggs are kind of around the same, if you will, age, so that they might be reaching maturity at the same time. But do you have any kind of rough sense, if you have this many follicles, you'll get this many mature eggs?
Good question. There's a huge variability in terms of how many eggs a woman is endowed with and how many she has at any given time in her life. And it can be unpredictable, even if you have regular periods, healthy person. Some women have very few eggs and some women have more eggs. And that doesn't actually determine their own fertility. You could be a very, very fertile person, ovulate every month, have few eggs when we look at the numbers, but actually not have any trouble getting pregnant. Having said that, if you have few eggs, you may not be a great candidate for going through egg freezing or embryo freezing, because that is really those numbers dictate how many eggs we're going to get with the process. If somebody comes in with fewer eggs, I know I have to put them on a higher dose of medication, and I have to tell them, like, listen, you may only get 3 to 5 eggs in a given cycle, whereas somebody who has much higher numbers, I could estimate maybe they get 10 to 20 eggs in a given cycle. So those numbers are really helpful to give us some idea of how they're going to be responding, but there's still some unpredictability to how many eggs you're going to get.
And I think one of the really important messages that we're going to come back to is no matter what you do with all of this stuff, you can always, that is not, and all these things don't necessarily predict your ability to go get pregnant the good old fashioned way. And that is always something that we like to emphasize, is that there's lots of ways to get pregnant. And this is one option. Okay, so that's egg freezing. And no matter what you do here, that's the first step, because you got to get the eggs out and available. Take us through embryo freezing. What are the extra steps that are necessary when now you're talking about an embryo rather than an egg?
Yeah, so we need sperm. So either you can use a partner sperm, which is most couples, if there's a male and female partner, we assess a semen analysis and see, well, does he have sperm? What's the quality of the sperm? So that's an important step in the workup. And then as part of or we can use donor sperm if they don't have a partner. Or a partner of the opposite sex, for example. But anyway, then the process is the same to retrieve the eggs. The only difference is once we get the eggs, then we have to put the eggs and the sperm together. If the semen parameters are pretty much normal, so if the sperm count is good, we can put the sperm and the egg together in the dish, and then we can just wait and see how many fertilize the following day. If for some reason we're worried about the sperm concentration, movement of the sperm, et cetera, or if we're doing genetic testing of the embryos to look for a specific mutation like BRCA, then we recommend doing ICSI, where we take the egg, we strip off the outer layer of cells, and we inject each sperm into each egg. And the reason why we do that is we want to avoid any contamination from additional sperm or, cells around the egg that could make it confuse the results of that genetic testing. So that's why it's recommended to ICSI. And then we typically, the following day, we see how many fertilized. So let's say we get 10 eggs, which is pretty average for a young person. We would expect 6 or 7 of them to fertilize. And then we grow them out in the laboratory. The embryo divides, and about half of them get to the blastocyst stage. That is an embryo that has about 150 cells, a fluid-filled center. It starts distinguishing, kind of differentiating into a placenta layer and the inner part that becomes the baby. And then we can freeze that embryo. Most programs freeze day 5, 6, or 7 of culture, and that's when you have a decent quality blastocyst. So out of those 10 eggs, you know, we said the 6 or 7 that fertilize, maybe you'll end up with 3, maybe 4 blastocysts to work with.
Yeah, I mean, it is, I often talk to patients about it's a numbers game. And it's each time, you know, you have to get eggs, but they have to be mature eggs. They have to fertilize. They have to look good once they're fertilized. They have to grow. So each of these is steps. And so we'll talk about how often people are kind of one and done on the cycle, but you know, it often isn't the case. That is sort of one cycle and you're done. Define ICSI for us.
Sorry. ICSI is where we take a sperm, intracytoplasmic sperm injection. So you take a sperm and you physically inject it into the egg.
But it's called like intracytoplasmic sperm
injection.
Right? Yes,
exactly, because we're injecting the sperm into the cytoplasm of the egg, which is like the liquid in the egg. Yeah.
Okay, so everybody, if you want to do pre-implantation genetic testing, you have to do the whole egg retrieval. You have to do the whole, got to make an embryo. That was a question, by the way, for several people. Can you test an egg or can you test a sperm? You're going to find out why in just a second. And so tell us about pre-implantation genetic testing, which, by the way, used to be called pre-implantation genetic diagnostics. So you might have heard PGD, and now sort of it's PGT. So next step.
Okay, so there's 2 types of pre-implantation genetic testing. One is if you are found to have a specific mutation, could be, in this case, we're talking about BRCA, but in other cases, there are other types of mutations that people carry that can cause disease. You essentially, the first step is finding out what exactly that mutation is. So we need the mutation report, and that typically they give you as part of your screening, your testing that you do. And then we send that to the genetic testing laboratory, and you have a consultation with the genetic testing laboratory. They are the ones who will develop a specific probe that's tailored to you to look for the mutation in the embryo. They have to get additional tests. They typically get cheek swabs to do DNA testing of you and your partner if you have one, and sometimes family members as well. And what they're looking for are genes next to the mutation, next to the gene of interest, that go along with the gene, so that they can tag those so that the test is more accurate. And so they can make a better diagnosis. Because again, when we do PGT, so what they do, so that's the process to develop the probe. And the laboratory side, what we're doing is you go through the IVF process, you get the eggs, you make the blastocyst. Then the embryology lab, essentially before they freeze the embryos, they make a hole in the shell of the embryo. They aspirate off 5 to 6 cells from that placenta layer of the embryo. The embryo is frozen. Then the cells are sent to the genetic testing company, and they amplify the DNA, and they basically run it through a platform, you know, to target and with the probe in order to identify which embryos are affected and which ones are unaffected with the mutation. So that is how you test for a mutation.
And just to you know, sort of, if you will, wrap it all up with a bow, you just heard they take out cells. Those cells don't go back. Those cells are used. And so you can't test an egg, you can't test a sperm because you only have one cell. So once you've tried to extract the DNA from it, it's no longer a cell. So that's why you have to use an embryo, and you actually use multiple multiple cells. Okay, so that's PGT for the specific mutation that someone might have. What other kind of PGT is there?
So then there's also PGT which is for aneuploidy screening. So what that is looking for, it's a screening test of the embryos looking for extra or missing chromosomes. And that is often an add-on test in patients who are doing the genetic testing to look for a specific mutation. They're already having the embryo biopsied. So they're saying, okay, well, I might as well screen it to see if there's extra or missing chromosomes. So why would there be extra or missing chromosomes? Well, unfortunately, nature is not perfect. And as a woman gets older, the eggs are actually become genetically abnormal over time. Typically, that happens in the late 30s, 40s. And that is why often embryos are, less effective. IVF doesn't work as well because you can make an embryo at 30. It works much better to have a baby, and transferring that embryo is more successful rather than when you're 40 and you transfer one embryo. It doesn't work as well because many of the embryos are just abnormal. Most abnormal embryos don't result in a pregnancy. If they do result in a pregnancy, often that pregnancy doesn't continue, you miscarry, or very rarely you can have a baby with some kind of a chromosomal abnormality like Down syndrome, which is an extra chromosome 21. But luckily, nature actually works quite well in sort of, preventing that from happening normally.
No, it's not just the women getting older, right? I mean, what happens with older men? Just so that's not all our fault, if you will.
I know we always blame it on the egg. It's very sad, but for men can have children at a much older age. Aging is not great for men either. Sperm, there can be DNA damage in sperm, but it's more point mutations and like little genetic problems that are less easily found. And PGTA actually does not pick those up. It only picks up big deletions, duplications, like big problems, which are more common with eggs. But you could have it from sperm as well. I mean, eggs and sperm are not perfect.
But I think what you just said is also a point to reiterate. When you go through PGT, you're not sequencing the whole genome for every last bad thing that could be there, because that technology is certainly not available and potentially not advised. But right now you're looking for sort of big changes that result in bad chromosomal things, and you're looking, in the case of PGTM, for the specific mutation that an individual would have. And by the way, either the man has it or the woman has it. I mean, unfortunately, the women have to do most of the work. The guy's job is pretty easy in all this, is that, providing the sperm is a little bit easier than all the shots in the retrieval. But again, the process is the same for a couple, right? Whether the woman carries the gene mutation or the man.
Yes, exactly.
Yep. So a lot of, there's a lot of, potential questions about things like cost and insurance. Now, recognizing that everybody's insurance is a little different, can you talk to us about sort of general principles of that?
Yeah, I mean, fertility historically has not been considered, or infertility has not been considered a disease. And so it's really one of those opt-in situations. Depending on your employer may cover it or not cover it in many, many states. Like Pennsylvania, for example, where we are, it's dependent on the employer. Luckily, more and more large companies and employers are starting to provide it as a covered benefit, which is great. Some states have gone so far to say, like, this should be a mandate. If you are working for a company of a certain size, they're mandating that it be covered to do IVF and fertility treatments. But there's a lot of variability in coverage, and I see lots of patients who have no coverage for even fertility testing, any types of treatment, and certainly PGT is the most expensive thing. And so that's a challenge.
And sometimes, people might have a benefit for infertility treatment, but the woman is not infertile and the man has a gene mutation. So really the coverage is for pre-implantation genetic testing, and there may not be any kind of benefit for that. So unfortunately, there are these, even these loopholes within loopholes, that it's not just if there's an infertility benefit, that's actually not the same as a PGT benefit. So it is getting, I do feel like it's getting much better. I mean, back in the early days, especially with breast cancer patients, which we'll probably touch base in a minute, we have patients who are newly diagnosed with breast cancer, and we sort of rapidly go through this process before they need chemotherapy. And in the old days, we were asking for grant funding a lot, and it feels like that's gotten a little better. Is that just my anecdotal experience, or?
No, it's definitely gotten better. I actually think, as ironic as it is, COVID, with all of the people leaving work, companies had to, there was like the great, whatever it was called, when people when people weren't working anymore, right?
Yep.
And so then companies had to start offering perks, I think, to their employees. And you see Amazon, Starbucks, Whole Foods, all these places now, it's a point of pride to say, like, we offer these benefits. And honestly, I have patients who change jobs in order to get benefits to cover some of these things, because they can be extremely expensive. I mean, we didn't talk about costs, but an IVF cycle with PGT can cost probably anywhere between $18,000 and honestly $30,000, depending on what kind of genetic testing you're doing. And that's a single cycle. And to Susan's point about the numbers, if somebody has 10 eggs, you only have 3 embryos, you may not have enough to build your whole family. And so you might need to do 2 cycles is very routine, and sometimes even more depending on the situation. So that's the challenge.
So tell us about the success. So the other thing is, back in the day, I would say that transfers were less successful. But tell us about now that you do more and more in terms of pre-screening, how likely is it to have a successful cycle if you have an embryo that's gone through PGTA and, it looks nice and healthy, at day 5? What is the success rate?
So I would say it probably is lab dependent to some extent, but I would say the majority of decent programs, the success rate is close to 60%. We could say 50 to 60% likelihood of having a baby per embryo transfer. That's when we put the embryo into the uterus after the uterus has been, prepared with hormones, etc.
But that's huge. That didn't used to be that high, right? I mean, those numbers have gone up, haven't they? Or maybe I'm just behind the times.
Well, doing the testing does not make the embryo any better. Let's remember.
Yeah.
The embryo is the embryo. So it's all about selection.
Right.
So now that we're selecting the one that made it, it looks good. And now we've done the screening. We've thrown out a few or put a few aside because they're not the best ones. Because when you select the best embryo, it has the highest chance. But overall, the chances, I mean, they've gone up, I guess, since the 90s, but there's questions around how much actually we've improved the technology, because it's inefficient and it still takes longer. With all the testing we've done, it should be better than 60%, right? Shouldn't it be better than 60% after you've weeded out all of the other ones?
So it's really that you've just gotten better at saying we're not going to transfer the eggs that don't look great because we are embryos that don't look great because they're probably not going to make it.
Yeah, but I will say that the embryo culture, we've gotten better at growing the embryos in the lab. Like, more embryos make it to the blastocyst stage than they used to. So we've gotten better. The methods of freezing have improved. Egg freezing was experimental around 11 years ago.
Right.
So literally it did not work. So in 2013, it came off the experimental list. And part of that was because advances in vitrification, there's this rapid freezing and thawing technique that we use for eggs and now embryos. And so that did move the needle, especially for eggs. Still, I would say egg freezing is less efficient than embryos because you lose more in the freeze-thaw process. Maybe 80 to 90% of eggs survive the freeze-thaw process. So, if you freeze 10 eggs, maybe you're down to 8 when you get down to it, and then you have to do the fertilization growth. Whereas with embryos, you use fresh eggs, and then at the end of the day, you know how many blastocysts you're working with, which is, a better endpoint in terms of knowing the future and what the success is.
Right. So that's I have lots of other questions, but that's a good segue into one of the most common scenarios now I'm asked about, which is, should I freeze my eggs? Should I wait, for a partner to freeze embryos? And I will be honest that remember that it wasn't that long ago that egg freezing was experimental, and now egg freezing is like covered by a lot of insurance companies. So it can be done. All right, so egg freezing can be done. And the question is, should it always be done? Or, what's the harm of waiting? And so often my perspective on this, and I'd love to hear from you, is that if I'm talking to a woman who's 25 and newly found to have a BRCA mutation, there is a lot that we're covering. There's a lot of information, a lot of things that are new. And I think that the issue is that her fertility is likely not going to change much between like 25 and 30. And between 25 and 30, you might have a partner. And if you have a partner, then you can freeze embryos sort of and not eggs. So I've always a little bit felt like we don't need to rush into the egg freezing because we've got some time. Do you think, tell me if I'm off base, or how do you think about this?
No, I mean, I agree. I think there's a general panic in the air. People are like, oh my God. I mean, we see people who are freezing their eggs for all sorts of reasons, often just because they're worried about the future. They're going to do, they're going to school for a long time, and so I think we've created an environment where if you have the benefit, you feel like you need to use it. And I think that everybody needs to step back for a second and realize it is invasive. You're doing injections for 2 weeks. It's a procedure you're having. While it's rare to have complications and problems, it is not fun. Like, if you don't have to do it, why would you do it? And it's better because the egg freezing is a little bit less successful and you really only know, like, I only have this many eggs. I still feel that it may not change the conversation at 30 when now you have a partner. We're checking his sperm. Does he have sperm? Like, are we doing the genetic testing of the embryos? At that point, you could buy your eggs, or you could go through the process and you'd probably get the similar results and maybe even better, because you're not freezing and thawing the eggs, and then you can grow them and know what you're working with in real time, closer to the time that you're actually going to utilize those embryos. The success of egg freezing is pretty good up until the age of 36. So through 35, I would say. So I generally tell people, 30 to 35 is a reasonable window. I think in certain situations, it might be reasonable to do it in your 20s or even in your teens if you have a diagnosis for cancer or something is going on. There's a lot more data on success rates also in people who freeze them in their late 20s and 30s because, that's what's out there in the literature.
Yeah, and I think it is also, it's a very personal decision, and so these but again, I think the messaging here is 25-year-olds have time. There's not an emergency. That doesn't mean that you can't have a conversation, but at the same time, there's a lot changes, between 25 and 35 for most people. That's a period of time where there's a lot of flux in your life, and so these are things to consider. There have been a few questions that are relevant to this in the chat. I think one we just answered, which is about whether it's best to have fresh embryos, or to use the frozen eggs. And you just heard about the freeze thaw considerations. Another question is, can you talk about whether it's common for BRCA patients to have all BRCA embryos? So here is statistics, which is it's a 50-50 coin flip every time. So each time, each embryo, it's a 50-50 chance. So that means you can have 10 embryos that all have it, or 10 embryos that none of them have it. I mean, if you add up thousands and thousands and thousands, it's 50-50. But unfortunately for each coin flip, it could be all or none, which I know doesn't always feel good. And certainly, and which leads to the next part of the question, that some women and couples end up with embryos that all have the BRCA mutation, and whether or not these can be implanted anyway. So I strongly feel, yes, this is, these are your choices. But Clarisa, talk about that discussion is always challenging, and
Yeah.
what are your thoughts? Yeah.
Well, because it's such a commitment in terms of cost, effort, energy, it's really, it's devastating for people when the outcome is not what they hoped. And so It's really hard because in your mind you have this idea, I'm going to have my family this way, and it's going to be, I'm going to have BRCA negative, it's all going to work out, I'm going to have to do this once, I'm going to be good. Well, the reality can be different than that, and that can be extremely difficult. Ultimately, the embryos are yours. Sometimes when that happens, we back up and we say, okay, well, you could try on your own. There's a 50-50 chance you have a baby that's affected or not affected, and rather than using those embryos. Or we say, okay, well, are they males? Are they females? Then we say, what's the risk of, health outcomes in a male BRCA carrier, for example, compared to a female? And is it reasonable to transfer that? And then maybe I might punt it back to Susan and her group to talk about those things. You could use things like, you could use, donor eggs, you could use donor sperm, depending on who's carrying. Those are options you could adopt. So we go back and just talk about like, okay, let's throw everything on the table and figure out what are your options, and then talk about it, think about it, take a break. I don't think there's any one right answer for everybody.
Yeah, I admit that I often have conversations with patients, and it can be really interesting how these conversations play out. We may have a partner, the husband and wife in a room. I once had a mother and a daughter in a room, and we were talking about pre-implantation genetic testing. And the mother said, "Oh, wow, that's awesome. I would have definitely done that." And the daughter turned to her and said, "Well, then I wouldn't be your daughter." And the mother didn't mean that, but it just sort of reminds us that these can be very challenging things to consider. And then I also always do talk about if you go down the pre-implantation genetic testing path, you may, as Clarissa just said, you may end up with no embryos that are unaffected. And then I always like people to think about that ahead of time, because, it's not a failure to be in that position at all. And you can just, a lot of people can go get pregnant naturally on their own. And then it's a 50-50 chance, and they, if you will, don't know. So for some people, they like that because it's still uncertain. Other people, I mean, I've had all these conversations about, oh, I know that the male embryo is BRCA negative, but I really wanted a girl, but that's BRCA positive. And it's like, these are your decisions to make. But the more that couples talk about it ahead of time, I think the better, because otherwise it's always, as you said, just devastating and frustrating and sad when it doesn't exactly work out as you might hope. But the more you're kind of like, well, if that happened, this is what we do. I think that people do better that way. There's another question about, if you're considering IVF PGT for future conception, how quickly can you do egg retrieval after giving birth? I have no idea the answer to that one. So
Yeah, so it depends on, are you breastfeeding or not breastfeeding? If you're breastfeeding, kind of the system is shut down, so to speak. Breastfeeding is a great contraceptive, so often you don't get periods at all, and you're not going to respond as well to stimulation if you don't give at least 3 months after you're done breastfeeding or giving birth, because again, your ovaries haven't been really working for a while. So I usually tell people to have a couple of normal periods after you're done breastfeeding or giving birth to, and then we usually check the hormones again, AMH, et cetera. Maybe we adjust the doses a little bit, and that's about it.
There's a couple of questions too about increasingly women may freeze eggs and embryos and then have their ovaries out. They've left their uterus in. I'm sure you've seen that situation before. Can you get pregnant?
Yes, so it's really, we can just stimulate the lining of the uterus with hormones. So we basically give the same hormones that are produced by the ovaries naturally. We give estrogen to build the lining of the uterus, and then we check the lining, make sure it's thick enough, it looks appropriate, and then we add progesterone. Typically, we give progesterone in intramuscular shots in the butt, which is not fun, but that is the preferred method for most clinics. And then we thaw and transfer the embryo, and then you continue the medications until through the first trimester, like 12 weeks of pregnancy, and then you can go off of it. The placenta takes over, have a normal delivery, all of those things. So kind of amazing.
Yeah, and it is actually amazing. When this first started to be done, we had to change our database because, you know, we had sort of as a fixed thing, once if you had your ovaries out, you couldn't get pregnant after that. It wouldn't let you enter that data, right? And we're like, oh no, that's not an error. Yes, we can do that now. So that was, I mean, that was years ago, but that was still sort of an interesting time. So how about if you, some women are having their fallopian tubes removed, and does that impact the success of IVF?
We do not think that removing the fallopian tubes affects the success of IVF, but in general, I guess whether to do it or not is more of a question, because if you happen to be one of those people who only has abnormal embryos or affected embryos and it doesn't work out well for you, then you have basically eliminated the option of trying on your own. And so I just would keep that, to Susan's point about talking about all the possibilities beforehand. I think being cautious and not doing anything that's going to damage your fertility in any way. IVF is not 100% effective. We still have a ways to go to, you know, perfect it. And so I would just be cautious about putting all your eggs in one basket, so to speak.
So, yeah, no, I feel pretty strongly about that. I don't think that it's a good idea to remove the fallopian tubes if one of your major goals in life is to be a biologic parent, because you just can't, no matter, honestly, no matter how many eggs, you know, eggs or embryos you have in the freezer, nobody can say that it's going to be successful. And so, yes, you can, the more embryos you have in the freezer, the more likely you are to be successful. But it's still, you know, again, I have had some patients say that there's absolutely no way they will get pregnant unless they can do PGT. Okay, if that is what it is, fine. But we always, you know, like to make sure people, you know, understand that. So let's talk a little bit about the hormones that you give and breast cancer risk and how you think about that. Does
hormones for stimulation?
Yes, the hormones that you give for the stimulation of the ovaries. Yep.
Yeah, I mean, I don't think, well, probably Susan can talk about it, it has her own opinions about this, but the stimulation, there's no evidence that fertility drugs in general, including drugs for IVF, increase the risk of breast cancer. There is some evidence around possibly increasing the risk of ovarian cancer, actually in the literature, but again, this is not in BRCA positive patients. So in BRCA positive patients, I don't think there's any clear evidence that it changes the prognosis. I think that obviously that increase the mutation itself increases the risk of breast and ovarian cancer. Even in the setting of breast cancer. So say you are diagnosed with breast cancer and you have to go through stimulation. We typically in that setting give medications to keep the estrogen levels relatively low during stimulation, just because we're concerned that maybe the high estrogen levels as part of stimulation in the setting of breast cancer could worsen the prognosis. Some studies have been done with those protocols that do not show that there's a decreased survival, increased recurrence, et cetera, when we use those protocols. Now, in somebody with a BRCA mutation who hasn't had breast cancer, I don't typically use any adjuvant medications like aromatase inhibitors like letrozole or tamoxifen. One could, but I don't think it's necessary. I don't know how you feel, Susan.
Yeah, there's data from a number of studies that doesn't suggest any increased risk with IVF for breast cancers, even specifically in mutation carriers. And correct me if I'm wrong, but the IVF and ovarian cancer, which was mostly seen in Scandinavian studies, it looked like it was for infertility itself, that the people who actually ended up having children didn't seem to have the ovarian cancer risk. Did I
That's part of it. It's very confusing when you look at the infertility population, because having infertility and never having children is an independent risk for breast and ovarian cancer. And so it's really hard to sort out the differences. There's also a problem with endometriosis. Some people with infertility have endometriosis and some other conditions that also put them at risk for ovarian cancer. So it's really hard to like sort out if there's really any true association.
But for BRCA carriers, you know, so that's just in general, but in BRCA carriers, there's been no evidence that using infertility treatments of any kind or, you know, for this purpose increases the risk. And for breast cancer, we do this, we view this as an absolute standard of care. If we have a young woman, well, if we have a woman who is not yet finished having her children, regardless of her age, as long as she still, you know, is premenopausal, if she wishes to preserve her fertility, we absolutely will do that. You know, there's been, you know, data about shutting off the ovaries during chemotherapy, but the most effective strategy is, you know, advanced reproductive techniques, is to freeze eggs and embryos. Someone asked a question, which I'm not sure is answerable, but how many eggs should you freeze if you're planning to do PGT later on, like roughly per child, you know, if you're like 35 at your egg freezing? I mean, I think this is hard. This is the problem, right?
Yeah, you can do the math of averages, which I gave you the averages of 10 eggs. So the success of egg freezing has been estimated for women less than 36 years of age, has been estimated to be about 6 to 7% for frozen egg. It sounds crazy, but it's a numbers game. So if you have 10 eggs overall, 60 to 70% chance of having a baby. You probably, if you're testing for BRCA, you need to cut that in half, because you're not going to transfer half of those eggs. So then 20 for that success. We usually say for a woman without BRCA, at 15 to 20 eggs is better than having 10, because the odds are much higher. It's more like 90% chance that you'll have a baby from 20 eggs, for example, in a young woman. So now we're saying, okay, I mean, I hate to even say the word, that 40 seems kind of insane, because that could be 4 cycles of egg banking, depending on how many you make per cycle. That's a lot.
But it does give you the idea that it really is, you know, again, how big you want your family and all of these things. But remember that this doesn't translate to natural pregnancies. So there's really never been any evidence that BRCA carriers have fertility issues. Like, meaning if they just go get pregnant, they kind of are able to get pregnant at about the same. There's been these minor things like natural menopause is a little younger. Well, okay, that's nice, but I'm not, unfortunately, allowing people to really undergo natural menopause anyway. There's been sort of some suggestion that during stimulation, maybe there's a fewer eggs. But Clarissa, we even did a study where we looked at AMH levels, and there really wasn't any significant difference in carriers and non-carriers, right? So
yeah, that's been a kind of all over. It's very controversial. And in my personal experience taking care of these patients, I haven't noticed any dramatic changes. Many of these patients do extremely well and have lots of embryos. So
there, you know, I think another issue that was sort of asked about before the chat, and I promise to everyone that this is not politics. This is medical discussion about reproductive access across our country. So, I mean, I think this is a real issue, unfortunately, that you know, there may be increasing restrictions. How are you guys thinking about this in the IVF world? I mean, it's a different world right now.
I mean, it's extremely troubling that we know about reproductive rights in general and, you know, abortion restrictions, but this is like next level. Now politicians are interfering with people's ability to create their families in the ways they want. And so in Alabama, because of the, you know, an incident that happened there, then they said, okay, embryos should be considered children. And then of course, IVF practices had to stop performing IVF because they were creating multiple embryos, and God forbid one doesn't develop to the blastocyst and they discard it. Are they going to be liable or, you know, called a murderer, for example? I mean, it's just insane to even think about that. So it's been very concerning because I don't think politicians understand the science. They don't understand the medicine. They don't understand what patients are going through. And it's just not okay for them to be trying to dictate this. So anyway, I would, keep in mind the importance of reproductive rights and encourage everybody and all of you to please vote, because that's the only thing we can do.
Yeah, and it is a real, I mean, this is, I've never in my career had to sort of, talk to, but I actually saw someone who came to visit me from Georgia, and I just, reminded her that this is a changing landscape. And it truly is a changing landscape, and it's hard to believe, but it is. Okay, another issue which is always a little bit challenging logistically. So we've been talking a lot about BRCA 1 and 2. We know that BRCA 1 and 2 mutations are much more common in the Ashkenazi Jewish population. So 1 in 40 individuals of Ashkenazi Jewish descent has a BRCA mutation. We also know that recessive conditions are much more common in the Ashkenazi population. So, now we're talking about things like Tay-Sachs, where sort of people are well aware that, Tay-Sachs is a challenging condition, and it's recessive. You have to inherit one bad copy from each parent. So, Clarissa, as you talk to patients about, PGT, how does the recessive conditions play into this all?
Yeah, so we do encourage all of our patients to get genetic carrier screening, expanded genetic carrier screening, which means that we, every practice uses a slightly different. There are various on the market, let's put it that way. The one that we offer has 176 mutations, and so we check both partners, and usually people do not line up and have the same mutations. One person might have 2 mutations, another person might have 3, but they're usually different. But occasionally you get a situation where both partners carry the same mutation. And then that's relevant because we can then test, there's a 1 in 4 chance of having a baby or an embryo that's affected with 2 and could potentially have the disease. So then we can do genetic testing for that specific mutation as well.
And that adds obviously to the complexity. So we already talked about the numbers games of the embryos. If you now have, 2 partners who both have a mutation for Tay-Sachs, then you're talking about screening for that as well. So, and again, there's conditions in all races and ethnicities. Cystic fibrosis is common in, Western Europeans, et cetera, et cetera. So this is just sort of another thing that is generally offered in the process of all this. And most of the time, the fertility clinics also, arrange this. But I often say for young women who are looking ahead, their gynecologist can do recessive carrier screening in advance. So you don't necessarily have to pile it all at once. But I do view it as an important component. And if people aren't going to do PGT, I still think they should consider recessive carrier screening, again, particularly in the Ashkenazi Jewish population. So it's just kind of another type of genetic testing. I think what I've heard, and I understand the feedback, it can be frustrating because BRCA testing is kind of over here and recessive carrier screening is over here. And it's a little bit like getting an MRI of your head and an X-ray of your knee. Like it feels like, isn't it all the same? But they're like different labs. They're not always different labs, but they're different tests. They're just completely different tests. They require sort of different insurance authorization and things like that. So we are trying to make this simpler. Actually, Clarissa, we were just talking to Rose the other day, the lead genetic counselor in reproductive genetics, on how to make this a little bit easier for people. I think that, again, most of the time, if you're going through PGT, this gets picked up. But if you're not going through PGT, sometimes people kind of forget about the fact that there's other stuff that you may be thinking about. One question, I'm going to paraphrase this question. Someone was asking, ideal time to have a baby. And I will tell you that I know it sounds weird, but that's a little bit, it's a very personal decision. For BRCA 1, obviously, we do talk about oophorectomy between ages 35 and 40. And once childbearing is complete, that is actually the full sentence. The risk of ovarian cancer by age 40 is less than 3%. For BRCA 2, that's 40 to 45. And by the way, it's hard to get pregnant naturally after 45. Clarissa can give us those numbers in a second. But the question here for you is, should I look for options to have twins to reduce the procedure timeline?
No.
And why? And why
Yeah,
not?
so, right. So people like the idea of having twins, one and done. It sounds like a good plan, right? But the reality is twins are actually complicated and dangerous. There's a much higher risk of having complications in pregnancy, birth defects in the actual twins themselves. Delivering early, you can imagine, double the size. The uterus is not intended really to carry two babies. So often what happens is women go into preterm labor, deliver early. The babies have to be in the intensive care unit. They may have complications related to that. They may not be feeding or growing well. So again, it's not advised. It's really, we have done a lot of work trying to reduce the number of twins in IVF by mandating like single embryo transfers, and that's really improved the health of children. So
And
even though
mothers,
twins sounds fun,
mothers have more complications too.
you're right. Diabetes, high blood pressure, needing a C-section. Yes, both sides. Susan is correct. So it's more complicated overall.
And can you tell us, again, this sometimes I find it helpful to kind of put, the understandable fertility concerns in the context of, if you don't have a BRCA mutation, how likely is it that you're going to be able to get pregnant after 40, sort of without any kind of reproductive assistance?
Yeah, well, shockingly, I mean, we think age is the question. First, I want to answer the question, when should you get pregnant? I think as soon as you are in a situation where you feel ready, hopefully partnered, etc., do not delay. There's no good time to have a baby. So it's better to do it when you're young and healthy, I think. So if that's before 35, that's great, especially if you have to look at potentially taking your, ovaries out, et cetera. So I think that would be my recommendation. Don't delay. It seems to be a trend. I'm not happy with this trend of delaying childbearing. And then fertility goes down because, as I mentioned, the quality of the eggs goes down. So at 40, 50-50 chance of getting pregnant on your own still, surprisingly.
Oh, that's actually higher than I thought. Yeah.
I know, but over 40, I mean, the devil's in the details. It goes down pretty quickly. By 45, the chances are almost zero. Like almost no one gets pregnant at 45 or after, and our technologies do not work. IVF does not make your eggs better. It actually is even harder to get pregnant with IVF at those ages than getting pregnant on your own, which occasionally happens just based on luck. The only way, what we do for those women who are 45 or older is often we use a donated egg from a young woman who's less than 33 years of age. That works very well. But pregnancy at 45, 50 can also be more complicated because just overall.
I do think we haven't been helped by if you will, the celebrity narratives of people who are significantly older getting pregnant, because that's generally not their biological material. By the way, it is not fair for women because yes, the men can get pregnant at much older ages, but it's unfortunately just a reality of the situation. And luckily, I think that since back in our day, when we were doing our medical school, pretty much no one got pregnant during medical school, but that's happening much more frequently. And I think that that's a really positive sign. So hopefully that'll continue, that people feel like if they're ready and they have their partner, that they can, move forward. I have a question that's a little bit more specific that I'll just quickly answer because it's about something called the positive trial. So this is related to this issue of if you have breast cancer, can you get pregnant after a breast cancer and when? And so in general, we say that getting pregnant after having had a breast cancer does not in itself increase your risk of your breast cancer recurring. There's been a lot of studies that have shown that. As so oftentimes we talk about this 2-year window, but that's a lot because we don't want someone to have a really bad breast cancer recurrence while they're pregnant, because honestly, it's a very, very challenging situation. So there was a really great study done by my colleague and fellow when I was in training, Ann Partridge, who looked at women who had estrogen receptor positive breast cancer, who took hormonal therapy to treat their breast cancer for 2 years and then stopped to have a baby. Because what we've always really felt that it's not getting pregnant that increases your risk, but it may be stopping your therapy that increases your risk. And in that study, over 70% of women, had a pregnancy, and there didn't appear to be any substantial or any increased risk of having their cancer recur but it was not a randomized trial. So it was as well done as you could possibly do it, but you can't randomize people to, stopping and getting pregnant versus not. That doesn't mean that people didn't get their cancer back. And so I think that it's still a very individual decision, weighing your goals, how risky your cancer is, and how you want to, whether you've got embryos stored, all of those things. And these are really complex discussions. I think Clarissa and I have them a lot. The other nice thing, though, which has happened, is that patients can get their egg stimulation on tamoxifen. So that's kind of nice for me, because I can have patients who are taking their medication to treat their breast cancer and at the same time go and store their eggs and embryos. So that's nice, isn't it?
Yeah.
So I think that we're sort of running towards the end of time. So I just wanted to sort of see if I had what things that have I missed, Clarissa? What are the common questions that you get?
Oh, you're putting me on the spot now.
No,
What are the common questions? I think the challenge, so I also see patients who are interested in using gestational carriers occasionally. So talk a little bit about being on the medication to prevent, even though pregnancy does not increase the risk of recurrent cancer, the medications prevent the cancer from coming back. So that's
right.
always like, what is that risk benefit ratio? And when some patients feel very strongly, they don't want to go off tamoxifen or, this ovarian suppression, and they want to use someone else to carry the pregnancy.
Right. And that is something that certainly, I have seen done. And again, these are, you can imagine people come to the discussion with their own. I often say it's like one of those old fashioned menu boards with the little slats that you get to put in order. And, you get to decide whether for some people having a biologic child is like the most important thing in their life. And our goal is to sort of give the information that people need to make those decisions. For other people, they're like, listen, I'm going to stay on this medication. I don't want any potential increased risk of recurrence, in which case then we're talking about potentially, waiting it out until they're finished their hormonal therapy with embryos in the bank, gestational carriers, adoption. I have one biologic and one adopted child, so I'm always very happy to talk to patients about those options. But there's lots of different ways to have a family, and I think we're just here to help people make those decisions. So with that, I think we are at time. So Clarissa, I really want to thank you for your expertise. You're always been incredibly helpful to me and to our patients, and to thank all of you for coming. So have a good night.